All right, good afternoon, everyone, and welcome to today's Recovery Summit presentation. The Recovery Summit is brought to you by St. Clair County Community Mental Health with support from the St. Clair County Health Department. Today's presentation that you're joining us on today is Advances in Diagnosing and Treating Chronic Pain. Before we begin, we'd like to go over some general reminders. Again, for those of you that have attended the webinar, for some of you, this might be new information. We ask that all of you go ahead and use the chat feature for any questions or comments. Our presenter, Dr. Claw, will be answering questions as time allows at the end. So go ahead and put your questions in the chat feature, please. Today's presentation offers one social work CE and one McBAP credit. If you're requesting professional credits, you must remain on the webinar for the entire time to lose credit. And for any reason, if you lose connection, just go ahead and reconnect on. A survey will pop up at the conclusion of the webinar. Those of you that are requesting social work CEs, completion of the survey is necessary. Now I'd like to go ahead and introduce our presenter for the day. Dr. Daniel Claw is back with us again. We've been very fortunate to hear from him before. He's a professor of anesthesiology, medicine, rheumatology, and psychiatry at the University of Michigan. He attended undergraduate and medical school at the University of Michigan, following which he did an internal medicine residency and rheumatology fellowship at Georgetown University. He stayed at Georgetown as a faculty member from 1990 to 2002, serving as chief of the Division of Rheumatology and vice chair of medicine. While at Georgetown, he founded the Chronic Pain and Fatigue Research Center. And in 2002, he was recruited to bring this group to the University of Michigan, where the group has become one of the most successful pain research groups in the world. He also served as the first PI of the University of Michigan Clinical and Translational Sciences Award, as well as the first Associate Dean for Clinical and Translational Research. He founded the institute that houses the UMCTSA, the Michigan Institute for Clinical and Health Research. He has over 450 peer-reviewed publications, over $100 million in federal funding, and is a very active member and mentor, serving as the primary mentor for 39 NIHK awardees, nearly all of whom have gone on to obtain R-Series funding or equivalent. We are so pleased to be able to have Dr. Claw here today with us. Dr. Claw, I'm going to go ahead and put the stage over to you.
Thanks so much. And next time that you have me, I'll remind you to not do such a long introduction. So I don't like listening to myself about myself.
Sounds good.
My disclosure slides, I do a lot of consulting with companies that are trying to develop non-opioid analgesics, and I have a bias, but it's a strongly scientifically based bias against opioids. I have testified against the opioid manufacturers in both the state of Oklahoma and the state of Florida. So I'm clinically trained as a rheumatologist. I start my talks with this slide because when I was trained in the 1980s, 1990s, we actually thought that if we did an x-ray of someone's knee and we saw that someone had this x-ray on the left, they would never have any pain. And that if we did an x-ray and we saw this x-ray on the right, they would always have pain. And it probably doesn't surprise you to know that about 10% of the people in the population that have severe knee pain have a normal x-ray, because there's a lot of things that could cause pain that you wouldn't see on an x-ray. But what should surprise you is that 30 or 40% of people in the United States population that have this x-ray, that have bone on bone in their knee, actually have no pain whatsoever. And most of those people are men. So I'll tell you why all this is in a few minutes. But what we now know clearly is that you can't see pain on an x-ray. Starting in the 1990s, studies of arthritis or of low back pain or of other types of pain conditions showed pretty clearly that there's always a lot of people that have a lot of pain that you don't find anything wrong on x-ray or MRI. And conversely, there's a lot of people that have abnormalities on their x-rays or their MRIs that don't have any pain whatsoever. So why is this? Why is there such a big disparity between what we see on an x-ray and what someone is experiencing with respect to pain? before I tell you the answer to that, this is my 30 or so year career in the field of rheumatology, where we went from, I was literally taught in my training that osteoarthritis was the classic peripheral pain syndrome, that by doing an x-ray, you could tell whether someone had pain. And it wasn't until the 1990s when these studies were done that I just alluded to that showed that a lot of people who had severe x-ray changes had no pain, and a lot of people who had pain had no x-ray changes. When people saw these individuals that had pain but no x-ray changes, they immediately thought this must be due to psychological factors like anxiety and depression and catastrophizing. But in point of fact, those psychological factors don't really explain much of the difference here. And I like including this in the slide because treatments that we used to think worked really well for osteoarthritis of the knee, like non-steroidal anti-inflammatory drugs or acetaminophen or opioids, we know now that a lot of these treatments don't work very well at all. Opioids, the latest meta-analyses clearly say you should never use an opioid to treat osteoarthritis of the knee because they don't work very well and they have tremendous safety issues. Acetaminophen doesn't work very well for chronic pain. And NSAIDs are helpful in probably 1 out of 3 people with osteoarthritis, but they certainly don't work in everyone. And even replacing their knee doesn't work in everyone. About 20 to 30% of people that have severe arthritis of their knee or their hip, when you replace their knee or their hip, don't have any improvement in their pain. So I'm going to talk a little bit about fibromyalgia, not as much as a standalone diagnosis. Our group is arguably the leading group in the world that's helped legitimize conditions like fibromyalgia. But the reason I'm going to talk about fibromyalgia is that our thinking of fibromyalgia has changed quite a bit since 1990 as well. The original criteria for fibromyalgia that were published in 1990 are here in front of, and you had to count how many tender points people had. You had to push in these 18 areas of the body with about 9 pounds of force. And if someone said they were tender, that was a positive tender point, and if they said they weren't tender, that was a negative tender point. And in order to diagnose fibromyalgia, the pain had to be widespread throughout the body. We got that part right. And people had to have a certain number of tender points, but we didn't know until well after the criteria were published that these criteria would bias towards diagnosing a lot more women with fibromyalgia because women are a lot more tender than men are. If you just push in different areas of the body in men and women, it turns out that women are more pain sensitive to heat or pressure applied to different areas of the body. And in fact, women are more sensitive to any type of sensory stimuli. Women are more sensitive to the brightness of lights, the loudness of noises, of odors. And you might wonder why I'm telling you that. It turns out that pain sensitivity and that sensory sensitivity that we see in conditions like fibromyalgia, and now we can see objective evidence of pain sensitivity and sensitivity to light, sensitivity to noises in conditions like fibromyalgia. And we see brain regions that are involved in coding for how painful is what's going on in your knee is coded by the same brain regions like the insula that tells you how bright a light is. And that one of the fundamental problems in conditions like fibromyalgia is essentially that these individuals are more sensitive within the central nervous system to both pain and other types of sensory stimuli. And believe it or not, if you're not a pain researcher, you wouldn't know this, but a couple of years ago, the International Group of Pain Researchers, who historically were very dismissive of conditions like fibromyalgia, because it's like, how do we know there's anything wrong with these people? They're probably just neurotic middle-aged women. That literally is something that I've had to fight against my entire career. Is you'd give a talk on fibromyalgia and then some idiot would stand up afterwards and say, well, yeah, but how do you know they're not just neurotic middle-aged women? Well, we can actually see on things like brain imaging and sophisticated research techniques that have become available in the last 10 to 20 years that these problems are very real. And now the International Group of Pain Researchers has coined this term, nociplastic pain, for this pain and this sensory sensitivity that clearly comes from the brain and the central nervous system And it actually helps us understand or explain, while we're never gonna be able to see, like on an X-ray or an MRI, why one person's experiencing pain and not another, because we really weren't thinking of pain in the right way. Um, and this is an analogy that I started using 15 or 20 years or so ago, and that is that the amount of pain that someone is experiencing is analogous or akin to the loudness of an electric guitar. And you can either make the noise from an electric guitar louder by strumming the strings harder, or by turning up the amplifier. And if I superimpose those two knees that I showed you earlier, the the knee or any other area of the body has all these nerves that are coming to it that pick up heat and cold and where the nerve is in space and pick up all this sensory information. But in order for that information to be felt as pain, that information has to go through the spinal cord and up to the brain. And um, using my electric guitar analogy, um, in the amplifier here is the central nervous system. So someone can have pain in their knee either because there's something wrong in their knee, or because their amplifier is set too high, that they are more pain sensitive and more sensory sensitive. And on average, women are more pain sensitive and sensory sensitive. So every chronic pain condition is 1.5 to 2 times more common in women than in men. And now we understand this. Now we understand that it's because women are innately more pain and sensory sensitive. If it wasn't annoying enough to be a female in this regard, if you're still actively menstruating, you often will get more pain sensitive and more sensory sensitive in the premenstrual phase of your cycle. But we now have come to understand that this is just one of the innate differences between men and women, and that the primary reason that all chronic pain conditions are 1.5 to 2 times more common in women than in men is that women have a higher amplifier setting on average for pain and sensory sensitivity. Now, for those of you in the audience that are women that are getting this news with despair, I'll turn it around and maybe make a joke. You've always known that men are insensitive. Literally, men are less sensitive to sensory stimuli than women. And again, now we understand that you sort of have to add together when you're seeing that person in the exam room in front of you that has pain. The pain could either be coming from the knee, or it could be because the amplifier is set too high. And the reason I continue to use the electric guitar analogy is that you also would understand that in many cases it's a combination of both. If you're strumming the guitar lightly, but the amplifier is turned up really high, then that person, the noise out of that electric guitar will still be quite loud. And that's what we see, is that people with conditions like fibromyalgia, even if they don't quite have fibromyalgia, they're just on the right side of the bell-shaped curve of pain and sensory sensitivity. If you happen to have a higher amplifier setting, then everything around your body, you'll have more pain than someone else does. If you have a mild injury to your knee, or you have a mild problem in different areas of your body. So again, what we have to do is sort of add together is what is that individual's amplifier setting, and what's sort of going on in their guitar. But we're really good in the US healthcare system already about interrogating what's going on in the guitar. We do all sorts of imaging and scopes and everything, looking at where the pain is coming from. But in a lot of individuals that have pain, the pain isn't coming from a problem in the area of the body where they're experiencing pain. It's coming more so because their amplifier is set too high, and they're literally experiencing pain in multiple areas of the body because of that. And so this is now our current thinking of the basis of conditions like fibromyalgia, but there's a whole bunch of other pain conditions such as irritable bowel, temporal mandibular disorder, tension and migraine headache, interstitial cystitis, bladder pain syndrome, endometriosis. Even more than half of the cases of low back pain are now thought to be this kind of pain that used to be called central sensitization, is now nociplastic pain, rather than pain that's due to a problem in that area of the body. There's damage or inflammation, or a problem with the nerves that are carrying that information from the knee, for example, to the brain. So you're going to more and more see this term. I don't like the term, but I wasn't asked about this term. It's here to stay. But this is a review article that we wrote in Lancet. There's been other review articles about nociplastic pain, but this is the term now that's being preferred by the pain community to describe these individuals that have fibromyalgia-like pain. And the way we can identify these people is their pain is going to be much more widespread. It's not going to be in a single location. It's going to be in multiple areas of the body. Going back to my analogy, if the amplifier is set higher, then any of the strings of the guitar would be louder if you strum them. But we also, the other part of the phenotype that we have come to understand is important in fibromyalgia or in these other nociplastic pain states is that these individuals, in addition to having multifocal pain, have fatigue, sleep, memory, and mood problems as part of their phenotype. And if you ask them, they are more sensitive to the brightness of light, the loudness of noises, odors. Another thing you can look at clinically, if you're seeing these individuals clinically, is these individuals will have in their list of quote unquote allergies. These are the individuals that'll have these really long lists of quote unquote drug allergies. Those are usually not drug allergies, they're hypersensitivities. And the same mechanisms that cause these individuals to be more sensitive to the brightness of light or the loudness of noises cause them to have more side effects of drugs. But we've seen this over and over again. I'm old. We studied this in the veterans of the first Gulf War, and we called this something different after the Gulf War. But you see these individuals with multifocal pain, fatigue, memory problems, sleep disturbances after war. You see this after terrorism. You see this in individuals that are diagnosed with cancer and then treated with cancer, the same sort of symptom cluster. This used to be called somatization, but now even psychiatrists have stopped using the term somatization because we know there is a biological underpinning. The term somatization really meant that these people were sort of making this up and there wasn't really anything really causing this. And many of us that have studied conditions like fibromyalgia our entire careers think that long COVID is the same as fibromyalgia chronic fatigue syndrome. And I think that more and more people are coming around to that, is that just like being deployed to war is a stressor that can trigger the development of a fibromyalgia-like illness, or being involved in a motor vehicle accident is, so is having a severe infection like COVID. And we know that there's a lot of pain conditions, not just fibromyalgia, irritable bowel, interstitial cystitis, endometriosis, vulvodynia, and the NIH in the US coined this term chronic overlapping pain conditions because we really now think that these are all sort of the same problem. It's just that if you have a problem with your amplifier and your pain happens to be in your bladder and you go to a urologist, interstitial cystitis is the name that urologists invented a long time ago for pain in the bladder when they can't really find anything else wrong. Irritable bowel, the name that gastroenterologists invented a long time ago for pain in the abdomen when they couldn't find an alternate cause. And now we know there is an alternate cause. The reason that people have pain is because of these sort of amplifier problems rather than it being a peripherally based problem. And moreover, we see that a lot of people that start with conditions like sickle cell disease or rheumatoid arthritis or lupus or osteoarthritis, where there really is something wrong out in the periphery, a lot of people over time develop this same kind of pain as we see in fibromyalgia. And so if you look at, for example, sickle cell patients that are now adults in their 20s, 30s, 40s, most of the pain is this kind of pain, not the nociceptive pain that they might have had in their childhood that usually accompanied the sickle cell crises. The new way of diagnosing fibromyalgia, or even more so, I would highly recommend that you give this piece of paper to patients or clients that you're seeing that have chronic pain, because if they fill this out, this will tell where they are on this continuum of their pain being more a regional problem that's more likely to be a problem in that area of the body. But the more widespread their pain is, the more boxes they check on this body map, the more fatigue, memory problems, and sleep disturbances they have, their score goes up higher and higher and higher. These are the new criteria for fibromyalgia. But the higher people score on this, what this is essentially saying is that more of their pain is coming from the brain, and that you should really treat these individuals like we treat fibromyalgia. You should keep opioids away from them because opioids not only won't work in these individuals, but will often make their pain worse. And you should be aggressively getting them sleeping better, getting them more active and exercising, aggressively using non-pharmacologic therapies to really manage this type of pain. And really think of fibromyalgia rather than being yes or no. Think of people having different degrees of fibromyalgia. And as Fred Wolf, who unfortunately just passed away a couple of weeks ago, was the first to really point this out, that we should really be thinking of fibromyalgia as different people are at different points in this continuum, rather than that someone either has fibromyalgia or doesn't have fibromyalgia. And so to give you an example, if someone comes into you and they have pain in their knee, and they have only pain in their knee on a body map, there's probably something wrong with their knee. But if they have pain in their knee and their body map looks more like this is a fibromyalgia patient. This person, his pain is coming more so from the central nervous system rather than from the periphery. And again, this is why just giving someone a simple body map can be incredibly helpful in just making that call. Is this more likely to be an amplifier problem, or is this more likely to be a guitar problem? A lot of people with these conditions like fibromyalgia, no one recognizes this. They continue to get surgery, opioids, injections that are not helpful at all, that actually might make them worse. And so it's at our peril that we don't identify people with these fibromyalgia-like conditions, because either they get frustrated and get, like the Titanic hit the iceberg, or we just don't make them better and they get incredibly frustrated and they develop more anxiety, depression, and catastrophizing over time, because they see provider after provider after provider that actually doesn't do anything to make them better. And in some cases says, there's nothing wrong with you, or it must be all in your head. And so there's a lot now understood about the old term for this was central sensitization. The new term is nociplastic pain. But if someone just has pain in their shoulder or in a limb, that's probably not very much of this. But a lot of people with low back pain and pediatric pain, osteoarthritis, have some of this fibromyalgia-like pain. And if you give them just a body map to see how widespread the pain is, or if you give them that fibromyalgia measure, which is the body map, plus asking about fatigue, memory problems, sleep disturbances, you'll get a better idea of where people are in this continuum. And if they're on this end of the continuum, you're going to treat them entirely differently than if they're on this end of the continuum. I'm just going to go really briefly. We actually have used surgery that is meant to relieve pain, knee replacement surgery and hysterectomy, as an experimental model. Again, we do a lot of NIH-funded studies that have helped codify our thinking about central sensitization, nociplastic pain. These studies, we hypothesized that on the day of surgery, if people were either getting knee or hip replacement surgery, or if women were getting hysterectomy for chronic pelvic pain, that on the day of surgery, if we gave them that fibromyalgia measure, that the higher they scored on that fibromyalgia measure, the less likely surgery would help relieve their pain. And the other thing we hypothesized was that the higher that someone is scored on the fibromyalgia measure, that it'd be the less well that opioids would work to treat the pain during their inpatient stay right after their surgery. And we were right. But these studies didn't just look at the fibromyalgia measure. We actually looked at anxiety, depression, all sorts of other things. It was just that on the day of surgery, when people were getting knee or hip replacement or hysterectomy, we gave them this measure and had them fill it out. And they get 19 points for how many areas on the body map they have. They get 0 to 3 for fatigue, memory problems, or sleep disturbances. So this is scored 0 to 9, and then it'd be 1.8 for these symptoms here. This can be scored from 0 to 31. And what we found is that in both hysterectomy and knee replacement, hip replacement surgery, and all of those surgeries in different studies, that as people's fibromyalgia score went up, they needed way more opioids to control their acute pain. As their fibromyalgia score went up, it was way less likely that they would benefit if you did surgery to relieve their pain, and that these things were independent of psychological factors. That this is just really people are innately different with respect to how pain and sensory sensitive they are. And this is really what's driving a lot of these pain syndromes like fibromyalgia. This is a data slide from the knee replacement surgery studies. On the bottom of the slide is the fibromyalgia score from 0 to 31. And the y-axis is the number of people that had that score. You can see that the most common fibromyalgia score in a group of people of 700 people that were getting knee replacement surgery was a score of around 5, but it didn't really matter. This is the 13 is if someone has a score of higher than 13, we say they have fibromyalgia, and if it's lower than 13, we say they don't have fibromyalgia. But it's a totally arbitrary point, because for every 1 point increase in the fibromyalgia score, people became less surgery responsive and less opioid responsive as they went up. And there was nothing dramatic that happened when they got to 13. To just show you an example of this patient here, patient B, doesn't have fibromyalgia because he doesn't score above 13 on that fibromyalgia measure. But look at how different this person is than this person. This person, they both had knee replacement surgery. Patient A only had pain in his knee and he had a little bit of fatigue. So he had on that fibromyalgia measure, he had a score of 2. Patient B had pain in his knee, had pain in a couple other locations, had a little bit of fatigue, a little bit of sleep problems, a little bit of memory problem, and he got a score of 11. Again, doesn't meet criteria for fibromyalgia, but look at how different these first people are when you do surgery on them. This person is 50% less likely to have a 50% improvement in their pain after they get knee replacement surgery or hysterectomy than this person. And this person needs way, way more opioids to control their pain in the initial inpatient stay, because this kind of pain is inherently less sensitive to opioid, this pain that comes from the brain. Drugs like duloxetine, the drug that you may know as Cymbalta, are going to work a lot better in this kind of pain. So this is a study that showed that if you Cymbalta or duloxetine, it's generic drug now, works 60% better in low back pain patients that have pain in 5 or more regions on a body map than it does in people with low back pain that have a single site of pain. And similarly, in someone with osteoarthritis, duloxetine might be the drug of choice when they have osteoarthritis of the knee or osteoarthritis of the hip, but the pain, in fact, is more widespread, because other studies have shown the same thing with duloxetine, that duloxetine works preferentially in the osteoarthritis patients with more widespread pain in addition to pain in their knee or pain in their hip. And so our group does a lot of functional brain imaging, quantitative sensory testing. This is what gets us a lot of the big NIH grants. When we were the first to do functional brain imaging and show that fibromyalgia was a legitimate disease, and we published this about 20 or so years ago, it showed that when we put fibromyalgia patients in a brain scanner and we pushed on their thumbnail, the fibromyalgia patients said that it hurt when we were pushing just very lightly on their thumbnail, because they have a higher amplifier setting. But we could see, even though they were applying light pressure, we could see that their brain was being activated, that the brain region that were involved in pain processing were being activated in those fibromyalgia patients, even though we were just applying light pressure, that the healthy controls said they barely felt it. We could get the healthy control brain to look like the fibromyalgia brain, but we had to give them twice as much pressure to their thumbnail. So this first study that we did and published in fibromyalgia in 2002 was really very instrumental in getting the FDA to start to think of fibromyalgia as being a real disease and to approve drugs for use in fibromyalgia. And then when our group and others replicated these studies over and over and over again in conditions like interstitial cystitis and irritable bowel, then now this is what led the broader pain field to say this is a real problem. This third mechanism of pain, nociplastic pain, is actually probably the most common type of pain when you look at the fact that conditions like headache, irritable bowel, fibromyalgia are incredibly common in the population, way more common than things like rheumatoid arthritis. Osteoarthritis would be an outlier there, and that certainly as people get older, that sort of becomes the 800-pound gorilla in causing a lot of the pain in elderly. But it's not just functional neuroimaging. We can now use other types of brain imaging and look at the degree to which different brain regions are either too connected to enough to each other or not connected enough to each other. And this is a fairly reproducible finding. Even the size and the shape of certain brain regions involved in pain processing change over time because of neuroplasticity in these chronic pain patients. And this is not from our group. Our group does a lot of work like this, but I don't just present work from our group. This is a different group that studied fibromyalgia, and using brain imaging and looking at a group of less than 40 fibromyalgia patients and 40 controls, they showed they could tell with over 90% sensitivity and specificity the fibromyalgia patients from the controls. So if you came into this talk thinking there's no quote unquote organic or neurobiological differences that can be identified in conditions like fibromyalgia, that's just because you're not keeping up with this literature. There's a fairly reproducible neural signature on things like brain imaging for conditions like fibromyalgia. The problem is that these aren't available now clinically. You can't order functional brain imaging. You can't do the kinds of things that we do on a research basis yet to people clinically. But again, this is very often superimposed. We do a lot of studies of conditions like rheumatoid arthritis or lupus, and a lot of people with those conditions that after they're initially treated aggressively with anti-inflammatory drugs for their rheumatoid arthritis or lupus, a lot of those patients are sort of left with fibromyalgia-like or nociplastic pain-like. So half of the people now with conditions like rheumatoid arthritis or lupus, even though our therapies for the inflammatory component of those diseases has gotten to be so much more effective, that a lot of these individuals still have sort of residual fibromyalgia or nociplastic pain, and more rheumatologists sort of waking up to this. And this is just that one of the drugs that's approved for use in fibromyalgia, milnacipran, which is a drug like duloxetine, actually worked in rheumatoid arthritis patients, but it was the rheumatoid arthritis patients in whom they didn't have much active inflammation, but they still had a lot of pain, fatigue, memory problems like fibromyalgia. And we've shown in brain imaging that the higher the rheumatoid arthritis patient's fibromyalgia score, the more their brain looks like a fibromyalgia patient on functional imaging. But in contrast, when a rheumatoid arthritis patient has a lot of active inflammation, and this is the sedimentation rate as a measure of inflammation, their brain on brain imaging looks quite different. So there might be a future state where we put people with conditions like rheumatoid arthritis in a brain scanner, and we see whether their brain looks more like the last study I showed you or this study that I'm showing you. But until then, giving someone that fibromyalgia measure, that single piece of paper, does that actually quite well. And that's how we're really trying to get rheumatologists to treat the comorbid fibromyalgia that's so common in people with autoimmune diseases. So why is this important? Because if someone has nociceptive pain, or if they have inflammatory pain, then opioids or corticosteroids or nonsteroidal anti-inflammatory drugs are going to be the drugs of choice. If they have this kind of pain that I've been talking about, those aren't going to work at all. The drugs that are going to work are drugs like amitriptyline. Cyclobenzaprine is one of my favorite drugs. You probably know this as Flexeril, and you probably think of this as a muscle relaxant, but it's a tricyclic drug. In a really low dose of cyclobenzaprine, 5 milligrams a couple hours before bedtime, can help a lot of people with sort of mild forms of fibromyalgia or nociplastic pain, probably because it does a really good job of getting people sleeping more deeply. Duloxetine is another drug that can be helpful. Gabapentinoids can be helpful. And we're not only not giving opioids, we're giving naltrexone. We're blocking the opioid system in these individuals because we actually think that in a subset of individuals, that hyperactivity of the body's own internal opioid system might be contributing to fibromyalgia, and that if that's the case, then that's the last kind of person you want to give an opioid, because you would actually make it worse. Excuse me. And this is an editorial I wrote in our leading pain journal about this problem of people on chronic opioid therapy that we didn't understand 25 years ago when we started to use opioids to treat chronic pain. It was a terrible idea. It's going to take us years or decades to try to get many of the people that are on chronic opioid therapy off chronic opioid therapy, because it simply doesn't work very well. But it's almost impossible to get people off of opioids because they become physiologically dependent on the opioids. They're not usually addicted to the opioids, but they're dependent. And in this editorial that I wrote, the analogy that I used, it's like putting someone on high doses of corticosteroids like prednisone. We know that as rheumatologists, we do this, but we know that if we keep people on those drugs very long, they have a huge number of side effects, and it turns off the function of the body's own internal production of glucocorticoids and of corticosteroids. This is a study that we did that's a sort of a cautionary tale. We did functional MRI and PET imaging in the same people with fibromyalgia controls, and our PET ligand was carfentanil, which is a highly, highly potent opioid. And in this study, we showed that it looked like the fibromyalgia patient's endogenous opioid system, their internal release of endorphins and enkephalins, they were releasing too many endorphins and enkephalins, which is what you would expect the body to do if you have chronic pain, because endorphins and enkephalins are released in response to pain or in response to stress. But we think these chronically high levels of endogenous opioids lead to what we call opioid-induced hyperalgesia. And again, why we think that if you give someone with this kind of pain an opioid, it's actually likely that you'll make it worse, not just fail to make it better. We have a lot of ongoing studies with cannabinoids now. The good thing, this is a cannabis plant talking to a poppy plant, and this is meant to be a joke, is that cannabinoids don't kill people like opioids do of overdose. Almost all the overdose deaths in the United States are because of combinations of alcohol, opioids, and benzodiazepines. The good news about cannabinoids is there are no cannabinoid receptors in the brainstem, and because of that, cannabinoids don't cause respiratory depression during an overdose, and because of that, they rarely, if ever, kill people during an overdose. And so we are doing a lot of work with cannabis. I'm a lot more excited about cannabidiol than I am about THC, because the people that are using THC to treat pain are probably using way too much of it. The data to date has really suggested that a low amount of THC works better than a high amount of THC. And unfortunately, a lot of people are going to dispensaries that primarily cater to recreational users, have a huge amount of really high THC cannabis. And if people use that to try to treat their pain, they're probably just going to get high and sit on the couch and be couch potatoes rather than actually get a meaningful relief of their pain. And so I just want to end by talking about how important it is to use non-pharmacologic therapies. These are increasing, the evidence base for these is increasing dramatically. And it doesn't really matter whether someone's pain starts as a guitar problem or it starts as an amplifier problem, that the longer people have had pain, and this is why sickle cell patients and rheumatoid arthritis patients and patients whose pain starts as a problem out in the periphery often becomes more of a central nervous system problem, because the longer you have pain, the higher your stress levels, the less active you are, the poorer you sleep, you gain weight, you develop bad habits. And all of these things feed back up into these central factors that will, again, sort of cause an increase in the amplifier setting. And we have to use non-drug therapies to really treat what's going on down here. There's no drug I can use to reverse the problems that occur when someone's sleeping poorly or they're not active enough, or they're and this is why we're aggressive about using a lot of these non-pharmacologic therapies that I'll put under the category of integrative therapies, because a lot of these therapies are therapies that we used to be dismissive of because we called them complementary or alternative therapies, things like, acupuncture, acupressure, yoga, meditation, Tai Chi. The evidence base for these has increased dramatically. Again, many of us think that long COVID is the same as sort of fibromyalgia, chronic fatigue syndrome, but that's a different talk for a different time. And I just want to contrast, when I wrote a review article on fibromyalgia that was published in JAMA in 2014, this was the evidence base for these different non-pharmacologic therapies. And you see the things like acupuncture, chiropractic manipulation, massage, we're all down here. And that there was one flavor of cognitive behavioral therapy for pain. And that we really thought that the main kind of exercise that would be helpful was aerobic exercise. This is just 10 years ago. Now, although these things have moved up to modest evidence, all of these non-pharmacologic therapies, many of which we used to be dismissive of because we didn't think they worked because they started in the Eastern therapies, or we were dismissive of chiropractic manipulation. All of these now, the evidence base is getting better and better for these non-pharmacologic therapies. And now we have 5 types of cognitive behavioral therapy we can use for pain. We can use pain-based cognitive behavioral therapy that lasts 8 one-hour sessions. We can use cognitive behavioral therapy for insomnia. There's brief 1-hour sessions of pain-based CBT now. There's acceptance commitment therapy, and there's emotional awareness therapy, which might be particularly effective for the people that have a lot of trauma that cause their pain. And I just want to say that I think we have to be careful about sort of over psychologicalizing pain. A lot of people with pain have a lot of anxiety, depression, catastrophizing, but a lot of the studies that are coming out now suggest that that's because they've had the symptoms a long time. They sought care for them, and people have ignored them, and they're anxious or depressed or think their pain is bad because no one has ever done anything about it. And we even see now, this is a study that our group published recently, Chelsea Kaplan's the lead author, where we see that you can see fibromyalgia-like pain coming in kids before they even start developing pain. We mined a very large study that's being done, still ongoing in the United States, that takes kids that are healthy at age 9 or 10 and follows them for 8 years and does functional brain imaging. And we looked at kids who at age 9 or 10 enrolled in this study and they didn't have pain. And then the next year they had pain in 2 or more sites in their body. They were moving towards having widespread pain. And on brain imaging, we saw half of the findings we see in adults with fibromyalgia, we saw in the kids while they were still asymptomatic. So again, there's really something neurobiological that's going on in these conditions like fibromyalgia that lead to pain sensitivity, sensory sensitivity, sleep problems. And the earlier that we identify these in individuals' lives and get them involved in some of these non-pharmacologic integrative therapies, the bigger the favor that we'll be doing. Again, what we see in the study we published just a couple months ago is that the biggest risk factors for adolescents developing fibromyalgia, like pain, female sex, having pain in other areas of the body, sleep problems, memory problems, and mood problems in kids were not a risk factor for subsequently developing pain. So our group tries to really teach people that when you see adults that have a lot of psychological comorbidities with pain, don't always think that the psychological comorbidities came first and caused the pain. In some cases, it's the other way around. And if you can simply make these individuals' pain better, their mood problems will get a lot better. Our group develops a lot of websites for people to use. This first website that we had for fibromyalgia patients worked really well. Just in fibromyalgia, it worked better than the drugs that were approved for fibromyalgia, but our new website is much better. This is free. I'd highly recommend you send your patients, your clients to this. It's called painguide.com, all one word, painguide.com. And it gives people access to a lot of these integrative therapies. They can just get it on the website, allows them to track symptoms. They can track different treatments they try. But again, we develop a lot of these websites and apps and things like that, and we really hope that people use them because we really think they can be helpful when you're out in practice trying to interact with pain patients and make their lives better. This is probably not very helpful for this audience, just some controversies in the field, except to say that we think diet might be helpful in treating this kind of pain. This was a study that we published several years ago where these were not people with pain. These were people that were obese that were in a program at the University of Michigan where they followed a really low calorie, 800 to 900 calorie a day diet for 3 months to try to lose weight. And in the first study we did out of this clinic, we showed that the people who came into this clinic, it turned out that a lot of them had pain, even though that's not what they were doing it for. And that when they went through this 3-month program, there was a significant improvement in pain and in depression and in fatigue and in fibromyalgia scores from the beginning of the program to the end of the program, just on the basis of being on that diet. And when we first published this, we erroneously concluded that it was due to the weight loss that occurred after 12 weeks, but we went back and looked at the data more closely and started to collect better quality data. And it turns out that most of the improvement in pain and fatigue and sleep occurred within 7 to 10 days. And it was clearly that there was a direct effect of this diet of caloric restriction that somehow led to this improvement. So now we're testing different types of intermittent caloric restriction and different types of nutritional interventions to see if these might in fact be effective in pain. And so this is my last slide. I always like having this be my last slide. In the VA health systems in the United States and the Department of Defense health systems, these are all the treatments that are approved and available to all chronic pain patients. And you see all of these integrative therapies that I had on my list now are used and available. And I wish all of us and all of the patients that we care for had access to and or reimbursement for all of these things. But wherever you are, whatever community you're in, and there are different of these providers that are available, and you can sort of create a virtual pain clinic to really provide integrative care to these individuals by trying to identify the people in your communities that are practicing some of these things and send more and more of your chronic pain patients to it. And my take-home message for managing chronic pain is have the patient complete that fibromyalgia measure so you see what type of pain they have, because that really is going to dictate your treatment. If they have this kind of pain that I've been talking about, think about managing their sleep or their mood or their fatigue rather than only focusing on managing their pain, because these things are all linked together, and making one better will make them all better. And then embrace the effectiveness of these non-pharmacologic therapies. If you tell your patients you think these are the most effective therapies and this is what they have to do, then this is what they'll do. And I say that I was recently quoted, the New York Times columnist Nicholas Kristof has written a lot about deaths of despair, because he came from rural Oregon, and when he moved back a couple of years ago from New York City to rural Oregon, half of the patients that he went to high school with had died of opioid overdoses. And he writes a lot about this, and he wrote an article recently about, how chronic pain is increasing in the population. And some of this is related to the same things that he was talking about. And my quote that he put in that article that he was writing about pain recently was, when you see a new patient with pain, the biggest favor you can do for them is show them something like this slide that I showed you earlier, where there's all these non-pharmacologic therapies, and you say, Mrs. Jones, which of these things haven't you tried that you would like to try? And how about if you try a couple of these things in the next year? Because each of these works in about 1 out of 3 people, and we don't know which people any of these are going to work in. So on average, if you can get people to try these non-pharmacologic therapies, and 1 out of 3 works, if they try 3 in a year, on average, one of them is going to help them a lot, and they'll retain that. And that's really how now we think chronic pain should be managed, by really trying to surround people with more of these integrative therapies, and use drugs and procedures more sparingly when the problem is a more peripheral based problem. So I'll stop there. I don't know what time it is. Perfect. I do this enough that I can do the talk. And I left about 10 minutes for questions.
That's great. Thank you so much. Lots of questions. One of the questions, Dr. Claus, how would you rate the success when fibromyalgia patients use gabapentin in place of duloxetine? I said that.
I think overall, on average, duloxetine's a more effective drug for these conditions than gabapentin, primarily because of the side effects of the gabapentinoids. The one thing that I would say about the gabapentinoids, they'll be a lot better tolerated if you give a single dose at bedtime, or if you give the most of the dose at bedtime. And some of the more recent work on how gabapentinoids work is they probably work at least half of the effect is by improving deep sleep. So if you do use these drugs and prescribe these drugs, especially the gabapentinoids, think about starting your patients on just a nighttime dose of one of them, and maybe just keeping them on a nighttime dose and thinking of them more as hypnotics rather than giving them 2 or 3 times a day, because I think they cause a lot of side effects. People get dizzy and they get a lot of fatigue and things like that. And I think it's really important to try to stay away from polypharmacy in these patients with fibromyalgia type conditions, because certainly I don't practice anymore, but when I used to practice, you'd get these people and they're on all these drugs and they don't know which ones are helping and which ones aren't helping. And so I think another principle to use when you're taking care of chronic pain patients is try one thing at a time, try it for a month or two, and then see if it worked or not. And then if it worked, keep it. And if it didn't, discard it. But make sure you discard the ineffective therapies. Otherwise, these people end up accumulating drug and non-drug therapies that are not really helping them anymore.
Makes so much sense. That really does. If our body's reactions are better prior to fibromyalgia, why are we waiting for diagnosis instead of prevention treatment in order to help reduce the prevalence of fibromyalgia patients in the population?
You're preaching to the choir.
Yeah.
If you look at the 450 or so articles that I've written, it's all trying to get people to take conditions like fibromyalgia more seriously, and especially try to identify them. Now, the reason that our group is doing so much work in the ABCD study and in pediatrics is we think that's where it starts, and that we could prevent. That we could prevent a lot of cases of fibromyalgia. Let me give you another analogy, because I tell people this and it's like striking to them. If I'm a rheumatologist, if someone with rheumatoid arthritis has rheumatoid arthritis that goes totally untreated for 10 or 15 years and then sees me as a rheumatologist, most of their joints will have already been destroyed by the rheumatoid arthritis. There's very little irreversibility to that if they have 10 or 15 years with no treatment. The same thing happens if someone has chronic pain. They accumulate functional disability, they accumulate psychological comorbidities as we allow them as adolescents or young adults to have these symptoms, not take them seriously, not get them more active in exercising, get them to focus more on their sleep, reduce their stress. But you're doing people that have a little bit of fibromyalgia a huge favor if you identify them. And a third of the people on this webinar I'm talking to be clear, because this is so common in the general population, is that if you have kids that this is highly familial too. And so if you have kids that are starting to develop these symptoms, or if you have clients that are starting to develop these symptoms, just try to nudge them into getting more active, getting better sleep, getting and more into these integrative therapies, because you'll be just doing them such a favor. I really do think that we can prevent the development of a lot of fibromyalgia, like not all of it, but a lot of it.
So like you had just said, just healthy habits and a lot of things that we do. I know this webinar is really heavy on like mental health clinical professionals. So just doing a lot of the things that we're doing to help out and to really encourage whole health wellness is so preventative with some of these chronic pain and things going on. It makes a lot of sense. I think it's really validating.
And destigmatizing as well. I actually don't recommend that you tell an adolescent that they have fibromyalgia. Because they might go on the internet and say, oh my God, if I have fibromyalgia, I'm going to be like all of these people that whose lives have been ruined by it. And so you have to be careful about how you do it. But when I used to take care of patients more, they would always bring in their daughters, and I'd say, just tell them that you would like a buddy on your walking program, or that sleep is so important. We're learning really how vital sleep is, and how cognitive behavioral therapy for insomnia, or some of the principles about going to bed at the same time every night are just really important. So yeah, start at the core, getting people active, getting them sleep better, reducing stress. And a lot of the treatments we use look a lot like wellness programs, because we are sort of aiming at some of these core systems.
Mm-hmm. And I think some of those things that we don't think of, maybe that, the non-pharmacological, I think as a treating professional for mental health, it's really validating to hear how a lot of the things that we do, like the cognitive behavioral therapy and mindfulness and yoga and those types of things that we're doing is very validating, knowing that those are as effective as you say they are in helping chronic pain. Right.
And if any of you do any types of cognitive behavioral therapy, which I suspect, just given the audience, some of you do, it goes by a lot of different terms. It goes by emotional awareness, neural reprocessing therapy. Some of the people that have published a lot on it are Mark Lumley, Howard Schubner. I don't think that it works nearly as well as they say it works, but it's a new type of cognitive behavioral therapy that I think it works extremely well for the subset of chronic pain patients that has a lot of trauma. So if you do give therapy and you're interested in sort of learning about that, I would highly encourage you, because we don't see any drug or non-drug therapies that can cure people of conditions like fibromyalgia, like we do occasionally see. Again, it might be 10, 20% of fibromyalgia patients that have this subset, but boy, I know the therapists that have started to use this really find it incredibly rewarding when they identify one of these patients. They use this kind of neural reprocessing trauma-based therapy, and it's like you flip a switch. And by the way, we're doing a lot of work with psychedelics. We just opened recruitment of a psilocybin trial in fibromyalgia, where we think that the therapy that is done in the participants of the trial will be at least as important as the drug, and that the psychedelic experience will open some people's minds to exploring some of these trauma-related issues that maybe people that aren't as open to them, if they don't have that psychedelic experience. So anyway, that's one of the directions that our group and a lot of other groups are moving, that there might be a subset of individuals with these conditions, again, especially the people with a lot of trauma, that we might really be treating in a fundamentally different way.
I find all the information completely fascinating. So definitely appreciate, Dr. Claw, all the information, the phenomenal work you do, just even on the visuals for everybody, the analogies. I think it really puts things into perspective for folks that aren't as familiar with this topic. So I appreciate that. And I think we appreciate it as a group listening to you today. So thank you very much. We're going to go ahead and just wrap up our closing. We know that there's more questions. We appreciate everybody's participation and questions. And we really want to thank you, Dr. Claw, for your time today. Thank you so much. So in closing, as a reminder, the Recovery Summit is going on all the rest of the month of September. We're not even quite halfway through it. We still continue to have many different topics and speakers planned each weekday. Tomorrow we have two presentations. So we have one in the morning at 11 a.m. presented by Shrita Harvey from My Lifeline Center on the Balancing Act, loving someone with an addiction. And the second of the trainings tomorrow will be at 2 p.m. And that is going to be presented by Devin France and Megan Kuhn. And they're going to be talking about DBT and the 12 steps. To see additional information, register for those two or any other parts of the series, please visit sccmh.org under the events tab and the Recovery Summit. And Dr. Claw is very willing to share all of his information that he shared today. And if you look under that tab in about 5 to 7 days, the copy of the presentation will be on there, so you could have all of that information, which we have found so very valuable. And as a reminder, individuals requesting professional credits for today, you will receive your certificate of all of your credits that you've accumulated for the webinar by October 30th. You'll get that via email, and you'll get one sheet with all of the webinars that you attended and your credits listed on that. As a reminder, please complete the short survey that will pop up at the conclusion of the webinar. We really appreciate all feedback. And thank you again, Dr. Claw. Your time and information is so appreciated today. And thank you all who attended this morning. Have a great day. Thank you.